Okay, so I'm Merrill. I'm a benign hematologist. All I do are blood disorders. I'm not a cancer doctor. I run the Hemophilia Treatment Center here at WVU in Morgantown. And if we can get this heading on. So just to take a brief second, I don't make any money from anything I'm going to tell you tonight. I don't get paid by Fernando. I don't get paid to talk about vaccines. I don't get paid if somebody uses a hemophilia factor or not. I don't make a dime if you use Kovaltry or Humate P. I don't get anything from that. So I don't get any money or personal gain from talking about hemophilia treatments or vaccines. My sole interest is to keep people out of the hospital. That's really all I care about. Whether or not they're my family members or my patients, I tend to be rather protective. So I will talk about 4 different vaccines that you will likely hear about in the news. I'll refer to these as their manufacturer name, just because the actual names of these things are a little long. So 3 of these vaccines have an FDA emergency use authorization, and you can get them now in the United States. That would be the Pfizer vaccine, the Moderna vaccine, and just as of last week, Johnson & Johnson. You'll hear about the AstraZeneca vaccine in the news, so I've included a little bit about it, but it's not yet available in this country. So why is a hematology specialist talking about vaccines? So what I like to do is keep my patients out of the hospital. One of the things I had been looking at that with is how many of our bleeding disorder patients get a flu shot? So for the last year, before COVID was a thing, I was tracking this. I would ask people when I see them, if they have a severe bleeding disorder, do you get a flu shot? And if not, why? So you see here from our bleeding disorder patients at WVU, almost 80% of people say, I don't get a flu shot. The small group here that does, a lot of those work for the hospital, so they have to. And when I ask people why they don't get a flu shot, some of those reasons are very insightful. Everything from, well, I'm young, I'm healthy, to I don't believe in them, to, well, I got a flu shot once, but I still got the flu, so therefore they don't work. So I wanted to sort of use that as a background about what I'll talk to you about tonight. All right, so to start from scratch, what is a virus? A virus is a very simplistic machine. It has one goal: to make more of itself. A virus is something that's made up of genetic information, either as DNA or RNA, and it's wrapped up in a covering of lipid, which is like oil, and protein. And that covering determines where that virus lives. Does it live in your skin cell and it cause a wart? Does it live in a blood cell, cause HIV? Or is it something that lives in your lung like COVID-19? Does this virus live in a human, or does it live on my cat sleeping over there on the sofa? So the COVID-19 virus is called SARS-CoV-2. It looks like a little soccer. So inside of this little soccer ball is the genetic material of the virus. And that is surrounded by the other components. So on the surface of this soccer ball is the spike protein. These are these little blips on the surface that cover the virus. And there are a few other components that make this virus structurally sound. So it's a little tiny soccer ball shaped machine with really one mission: to get into your body and make more of itself. So what does a virus need? Well, it needs you. It needs to get inside your body. How does that happen? Take a deep breath in. It got in. All right, what else does it need? It needs to attach to your cells and get inside of them. And to do that, SARS-CoV-2 or COVID-19 uses that spike protein. That covering of that little machine is the key that lets it into your cells. It tricks your cells into letting it in, and then once it's inside, it takes over. It uses your individual cells as virus factories. One cell gets infected, It makes a bunch of virus that infects other cells, which make more virus. And before you know it, one little virus turns into a huge onslaught. And then the cycle repeats. Someone else gets it, and it starts all over again. So who is at risk of COVID-19? Everybody. It doesn't look like people with bleeding disorders are at an increased risk, which is good, but almost everything else seems to be a risk factor for COVID. One of those risk factors we can't do anything about is age. Now, I'm at increased risk because I'm not a 18 or 20-year-old. I'm not 65, so I'm in that middle ground. But lots of other conditions that are common make it more likely to get severe COVID-19 or to die from it. Heart disease, lung disease, kidney disease, simple things like high blood pressure. Obesity. Here in West Virginia, about half of our patients are obese. That's a risk factor. Diabetes, smoking. Some other conditions that I see put people at a very high risk. HIV is quite interesting because, as studies have shown, it doesn't look like HIV makes somebody have an increased risk when you control for other factors. But of course, not everybody who has HIV is the same. If you have HIV and you're on your medicines and the HIV is well controlled, it makes perfect sense that that would be less of a risk than perhaps someone who doesn't know they have HIV and they have immune suppression because of that virus. And throughout the talk, the scientific studies that I'm referencing are listed here at the bottom. None of this information is taken from a Facebook page. It's all scientific information. And I'll pepper it with some of my own observations from taking care of people. COVID-19 is tricky because a lot of people will have no symptoms whatsoever. We know this from a big outbreak on the aircraft carrier Teddy Roosevelt. So think about it. Who's in the Navy? Pretty young, fit people. But this ship with almost 5,000 people on it had an outbreak, 1,200 cases of COVID, but 43% of them had no symptoms whatsoever and never developed symptoms. So this is why COVID is a problem. You might feel fine, but you go visit grandma, not realizing you're carrying a virus. 2 weeks later, grandma's not doing so well. When people get symptoms, it's things that you would expect. Headache, cough. COVID-19 is a little unique because of this changes in taste or smell. Sometimes people can't taste things, but body aches, chest pain, shortness of breath, everything that goes along with having a cold or a flu. But unfortunately, as we're learning, COVID is not just a cold, it's far worse because of the other problems that COVID causes. Now, this usually starts out as a lung infection. So pneumonia, fever, and low oxygen can occur, and this is relatively common. But we're also finding that 60% of people have heart damage. And me as a blood clot specialist, bleeding disorder doctor, I see tons of people now with blood clots because they got COVID. They may be 20 years old, but they're in the hospital from a large blood clot simply because they got COVID. This process can also cause spontaneous bleeding called disseminated intravascular coagulation, strokes, kidney failure, shock, and cardiac arrest. And as we're learning more about COVID, probably the more scary thing about it is not the 2 weeks when you feel sick or when you're in the hospital. It's months later when you don't get back to normal, even if you're a young, healthy person. Now, in the news and in the press, they call this long COVID syndrome, but it does happen. Some people will have no symptoms. Some people will have 2 weeks of feeling crummy. But if you guys see me for your hemophilia care, you likely know Megan, who takes your blood pressure. She's been out of work for 4 weeks because she got COVID, 4 months, not 4 weeks, because she got COVID from an outbreak at her church. So she hasn't been able to come back to work for 4 months because she got better, but she's still having all of these other problems. And if we look at CAT scans of somebody's lung, kind of shown here in panel A and B, yeah, when you get a pneumonia, we see this change in the lung, but a month later, that's been replaced down here on the bottom by scarring of the lung. So it's not just you get sick, but it causes lasting damage. All right, so how do we beat COVID? How do we beat any virus? We take away what it needs. So if it has to get in the body, we limit how it gets in the body. Wearing a mask so you can't breathe it in. Wash your hands so you don't accidentally give yourself COVID from scratching your face. Avoiding crowds, time near people who might have the virus, because again, a lot of people have no symptoms. You can pass the virus on before you know you're sick. And a vaccine helps at this stage because guess what? If my uncle never got COVID, he wouldn't have given it to grandma. All right. We can block how it attaches to the cells or gets inside the cells. We could do this with antivirus drugs or special antibody therapies. However, these have been mediocre at best. Well, why is that? Right now, we have great medicines for things like HIV and hepatitis C, but it took decades to get them. Well, COVID just came like last year. We don't have great treatments yet. But a vaccine is a way to train your own immune system to make your own antibodies so that when COVID comes knocking on the door, somebody's home to not let it in. The virus can take over your cells. Ideally, if we had an antivirus drug that helped work very well, this would be helpful at this step. But a vaccine is also helpful because it trains up immune system cells called T cells. We'll talk a little bit more about those coming up. And then we block the cycle. If you wear a mask, you're not broadcasting COVID. If you wash your hands, you're not leaving it around on things where other people could touch them. If you avoid people who could get the virus, you don't spread it. And if you are spreading virus for 10 days, as opposed to 1 day or 2 days because you got the vaccine, hey, you can cut down on this cycle. All right, so talking about vaccines, what is a vaccine? A vaccine is a tool to train your immune system to fight an infection before it happens. Like practicing a musical instrument before a concert, training before the big day of a marathon, or I like the comparison of if you want to be a firefighter, you go to Firefighter Academy. Now, if I wanted to be a firefighter and I jumped on a truck right now, I wouldn't have any idea what I'm doing. You have to train before you're ready for the fight. Vaccines can be made in many ways. We'll talk a little bit about them, but this is really old technology when you think about the process. Frankly, some vaccines have not worked. The medical community has been working on vaccines for HIV and hepatitis C for decades. They have not worked. They just have not been successful despite all of our best efforts. Some vaccines work very well. These are diseases I have never seen in my medical career because they're really rare now, if they exist at all, because of a vaccine. Smallpox, measles, polio. These were horrible diseases that now, like smallpox, don't exist anymore. They've been eradicated. Or measles and polio, we rarely see these. How did this idea start? Well, this idea has been around before our country existed. The earliest reports are from the 1700s, something called variolation to help with smallpox. But an Englishman named Edward Jenner is thought of as the father of vaccines. This was from something that he did in 1796. This was his publication from 1799. Edward Jenner was worried about smallpox. And comparatively, smallpox is way worse than COVID-19, don't get me wrong. This is highly contagious. It kills half of people who get it. And if you survive, you're either blind or disfigured. Smallpox is so dangerous, it's classified as a bioterrorism agent. It only exists in 2 laboratories in the world, one in the United States, one in Russia. This is what it would look like if you saw somebody with it. You'll notice that this poor child is covered with pox. These are pustule lesions all over the skin. These happen inside the body as well. And Edward Jenner got this brilliant idea because of something that he observed. People who milked cows didn't seem to get smallpox. And he said, that's really weird. Why does this not happen? But he noticed they had something that looked like these areas on their hands from touching the cow udders. Well, it turns out the people milking the cows picked up this cow virus called cowpox. And his revolution was that that virus protected you against smallpox. So Edward Jenner's contribution to humanity was the crazy idea that if you get a cow virus, it trains your immune system so that you don't get smallpox. Revolutionary at the time, people thought he was nuts. This works because it trains the immune system. Now, there are lots of immune system pathways, so the general simplification is you have T cells and B cells. B cells make antibodies. These special proteins float around in your body. They can neutralize virus. And I like to compare the antibodies to a firefighter with a pump truck and a water can, or a firefighter in an aerial bomber dropping water on a wildfire, right? You can put out the flames. The T cells are special immune cells that crawl throughout your body looking for things that don't belong. If they see it, they eliminate it, they zap it. These are sort of like smoke jumpers. The crazy firefighters who jump out of planes, parachute behind the fire lines, cutting fire breaks, putting out hot spots. So this is how your own immune system protects you from viruses. But if it doesn't know what it's looking for, it takes too long to keep you safe a lot of the time. There are lots of vaccines in development for COVID. This is just a list from the end of 2020. You'll hear a lot about these in the news. For example, China has 4 vaccines. Russia is working on a bunch of other ones. Lots of different technologies are being used here. So some of the ones we'll talk about today, Edward Jenner, he used an attenuated live virus. 2 of the vaccines we'll talk about today use a non-replicating viral vector. This is a different virus that is not COVID-19. It's been taken apart to not work, but it looks just like COVID-19, so it trains your immune system. 2 of the vaccines we'll talk about today are RNA-based vaccines. These use a teeny droplet of lipid similar to oil, and inside that is some genetic material to train your immune system. So none of these vaccines that we'll talk about alter your DNA. They're not gene therapy. They're something that's temporary to train your immune system. So briefly, the Pfizer or BioNTech vaccine is an mRNA vaccine against the spike protein of COVID-19. And how I explain this to my family members or patients, I say, this is a virus-like spike gene wrapped up in a carrier. It gets your body to make the spike protein from the virus to train your immune system. But importantly, this is not a virus. It does not make virus, and it's safe in people who don't have a working immune system. This isn't going to turn you into the zombies from 28 days later. The Moderna vaccine is very similar. Same technology. The mRNA is slightly different. So comparing these 2 vaccines, it's really like comparing a F-150 to a Ram 1500 pickup truck. Yeah, they're slightly different, but they both are the same sort of technology. And if you took one apart, you'd have a hard time knowing, did this come from the Ford? Did this come from the Dodge? The AstraZeneca and Johnson & Johnson vaccines are slightly different. And I mention AstraZeneca because it's in the news a lot. The AstraZeneca vaccine uses a chimpanzee cold virus. So this is called an adenovirus. It's been specially designed to make vaccines. So they take this thing apart in a laboratory, they make it non-functional, but they put in part of COVID-19 so that it looks like COVID-19. So this is a virus, but it doesn't reproduce in people. So if you get this vaccine, you don't develop chimpanzee cold problems. And it's also safe in immunocompromised people. The Johnson & Johnson vaccine, which I'll mention just briefly today, this uses a similar technology, but it uses human adenovirus 26. This is one of the many human adenoviruses that cause colds. This has been taken apart, so it's no longer functional. They put in the spike protein of COVID-19, so it trains your immune system. So this is a virus, but it doesn't reproduce in people. It's safe to use in immunocompromised people who don't have a functioning immune system. And I mention immunocompromised specifically because some vaccines use a live virus. We avoid those in people who don't have a working immune system. So one of those vaccines that we avoid is the MMR vaccine because it has live components to it. So these are very different. All right. So how do we know these things work? How do we know they're safe? In medicine, we have a high bar for proving something works and that it's safe. And we do that with something called a randomized clinical trial. To do a trial is actually pretty tough. You need a big group of people who are willing to participate. And if we're talking about football fans, we don't make it one team versus another because that could mess up your results somehow. What if Packers fans are simply not reliably immunized? So you take a big group of people, you say, look, you won't know what you're getting, neither will your doctors. Half of you will get vaccine, half of you are going to get an injection of salt water because we have to prove that the vaccine actually does something and that it doesn't have some sort of weird problems. Half of patients get treatment A, half get treatment B. Nobody knows at this point which one's which. That's important. And then you wait a few months and you see what happened, which treatment worked. After the trial's done, then you take the blinders off and you figure out, okay, group A, they got the fake saltwater vaccine. Group B got the real vaccine. So the trials. This is the actual data that I tell patients about and that I use to make a decision. This trial for the Pfizer vaccine excluded some people. People who had an altered immune system or people who had a bleeding disorder. Why would they do that? Well, they wanted the trial to show, does this vaccine protect against COVID? They didn't want the trial to show, hey, if we give someone an injection in the muscle, you get a hematoma if you have a bleeding disorder. So they didn't want that muddling up the results. The Pfizer vaccine is given in 2 doses. It's the same vaccine, you just get 2 shots of it. One is a booster, 3 weeks apart. This trial did include some patients age 16 to 18, but pretty much everybody was age 18 and up. And importantly, they looked at people's symptoms and then tested you for COVID if you had symptoms. Now, compared to the fake saltwater injection, more people had pain at the site with the vaccine. So 60 to 80% of people had pain. This was mild to moderate in severity. 5% of people noticed redness or swelling at the site. I have had this vaccine. It does feel like someone punched you in the arm, but it's not like being clobbered by Mike Tyson. What sort of things happen? Now, because this is a 2-dose vaccine, on the top, we're looking at the first dose. And importantly, we have to compare that against placebo. So placebo is the saltwater injection. Because if somebody told me, hey, Sam, I'm going to give you a medicine, it might make you feel crummy. Well, guess what? There's a good chance I might feel crummy even if I don't get the medicine at all. So comparing these two, with the first dose, very few people had fever, fatigue, headache, muscle pain, joint pain. There was a little bit more with the vaccine compared to the saltwater injection, but a third of people who had an injection of saltwater, which doesn't cause any problems, said, hey, I feel tired. Now, when we look at the second dose, you see a big difference. More people had fever, fatigue, headache, chills, muscle pain, joint pain. You do feel crummy for a day or two, especially after the second dose. This is because your immune system getting trained up. It's kind of like if I got thrown into basic training, it would kick my butt. That's how you know it's actually doing what it's supposed to do. But not everybody has these symptoms. Does it work? Yes. So shown in the blue here are the people who got the saltwater fake injection. How many of them got COVID? Well, over the 120 days of the trial, about 2.5% of people did. The red line are the people who got the vaccine. You'll notice these are different. So this is where that 95% protection comes in. And just to highlight something over here, you notice that these two curves kind of break off from each other. That's because it takes time to train your immune system. If I got my COVID immunization right now, and 5 minutes later I get COVID from touching a door handle or somebody coughs on me, I'm not protected. It takes time for the vaccine to train your immune system. And down here at the bottom, you can see that this trial had more than 40,000 people in it. This was a huge trial. After getting the vaccine, 2 people got COVID over here after the second dose, compared to over here, we got a lot more people, 9 versus 172. But in this big group of 40,000 people, we're talking about, 300 people got COVID. This was way before the big peaks. All right, so this is where this 95% efficacy comes from. If you get your second shot and you get enough time to train your immune system, this is the numbers we're talking about. 162 people, if you get the fake vaccine, got COVID. Only 8 did with the vaccine. So that's where that 95% comes from. So for the Pfizer vaccine, yes, it causes fatigue, muscle aches, headaches, chills, and pain at the site. Yes, that is extremely common. But it is very effective at preventing symptomatic COVID-19. Other effects, things you might notice, a swollen lymph node. So I had this after my second dose. As a blood specialist, I thought, oh, good, there's a little lymph node there. It went away 3 days later. Out of that huge trial of 40,000 people, 1 person in the vaccine group had tingling in their leg. 1 person had a funny heart rhythm. None of the people in the placebo group did. And let's talk about severe COVID. So 1 person in the vaccine group got severely sick, 9 did in the placebo. And if you look at 40,000 people for 4 months, someone is going to die of something. Nobody died from the vaccine. There were actually more deaths in the fake vaccine arm. And what people died from wasn't from a vaccine or getting a fake injection of saltwater. The Moderna vaccine is very similar, comparing pickup trucks to pickup trucks here. 2 doses, 4 weeks apart. They assessed symptoms. Pain at the site was common. 80 to 90% had mild or moderate pain, but 5% of people said, yeah, this is pretty severe. Redness and swelling at the site was about 10%, so more than the placebo injection. Looking at the side effects, fever, headache, fatigue, muscle aches, joint pain, nausea, vomiting, chills. When these are found, it's usually after the second dose of the vaccine. So the first dose primes the immune system. The second dose really riles things up. That's what it is intended to do. And again, this vaccine protects you from COVID. Now in this trial, we're talking about 30,000 people, 2 weeks after the second dose. In the fake vaccine group, 200 people got COVID compared to 12 with the vaccine. So that gives you that high efficacy. So just like the other Pfizer vaccine, fatigue, muscle aches, headaches, chills, pain at the site were common. But this was also very effective at preventing symptomatic COVID. A few other things they noticed in this trial: allergic reactions, hives, etc. 1.5% of people with the vaccine compared to 1.1% with the saltwater injection. Bell's palsy, which is a facial nerve palsy, so the nerve doesn't work so well. This was noticed in 3 people in the vaccine group compared to 1 person in the placebo group. Severe COVID. Of those about 300 people who got COVID, none were severely ill with the vaccine. 30 were severely ill in the placebo group and 1 died. Nobody died from the vaccine or from the fake vaccine. And if you follow thousands of people over several months, someone is going to die of something. So just very, very briefly, Johnson & Johnson. I can't give you a lot of details because this just got approved and the study isn't available for doctors to scrutinize. But in the pre-trial, they looked at 2 groups of people, 18 to 55 or older adults age 65 or greater. What's nice about this vaccine is a single dose, and it can be stored in a refrigerator. The Pfizer and the Moderna vaccines are a little tricky because they're 2 doses, and they have to be stored at very cold temperatures. So pain at the site was less of an issue with this. There was 1 injection. And from the dose finding study with this 1 dose, you see that, yes, people got fatigue, headache, muscle aches, nausea, fevers. But these go away pretty quickly. So people will ask me, well, this is great. We're going to get rid of COVID with a vaccine. Sorry, that's not going to happen. Why would I say that? Well, look at any other virus. Measles, for example. This was eradicated from the United States in the year 2000 with a vaccine. All it takes is 1 person going to Disneyland who's sick, and they might not even know it. They gave measles to a bunch of other people. They take it home. 306 cases from the Disneyland outbreak. 1 person died. So even though we have a vaccine against measles, this is not an invincibility shield. Vaccines reduce the chance of an illness. They reduce the chance of being critically ill or dying from that illness, but they don't eliminate all risk. They're like any other medicine. Nothing is 100%, but they only work if they are used. So recently in clinic, a patient with hemophilia actually asked me, well, doctor, if vaccines work, why are you wearing that mask? So here is my mask that I wear in my clinic because I don't want to get COVID. And I said to him, well, it's like a seatbelt in your car. The vaccine helps keep you safe, but you want to take other steps, just like wearing your seatbelt in your car. That doesn't give you permission to drive like a maniac. Well, he looked at me and said, doctor, I don't believe in seatbelts. Well, all I can say is I can't make that decision for you. All I can do is give you the information. So wearing a seatbelt in the car doesn't mean it's okay to drive like a maniac on an icy West Virginia mountain interstate in a snowstorm. Some people do. They're the ones who end up on the side of the road. But if you don't wear a seatbelt, it can't help you if you happen to lose control on the icy road, or if someone else loses control and then crashes into you. That's where the masks come in. Now, any mask is better than no mask to minimize the spread, and a good mask helps block the virus spreading. This is from experiments. So here we have 2 mannequins. They're put in a box. One coughs out COVID, and the other one breathes in. Over here on the left, this is the viral titer. So this is a logarithmic scale, powers of 10. So we're talking 10, 100, 1,000. If coughing mannequin wears no mask, lots of virus gets inhaled by the other mannequin. If you put something simple on there, like a cotton mask on the coughing mannequin, the amount of virus drops dramatically, but it's not zero. Even with a high quality mask, virus is still getting out. With a very good fitting, high quality mask, the amount of virus drops off even further. So again, a mask is not an invincibility shield. A mask also protects you from others. Any mask is better than no mask. A good mask reduces virus inhalation, but it's not an invincibility shield. You know, this crazy thing right here is very effective, but I am going to get COVID even if I wear this, simply because it's not 100%. So in the mannequin experiment here, coughing mannequin with a mask, breathing mannequin with a mask, you still inhale virus particles, but a mask does cut it down. All right, so how does someone with bleeding disorder get a vaccine safely? In all of these trials, they looked at intramuscular injection. That's the type that we know can cause a hematoma if you have a bleeding disorder. So please let your hematologist know. But for my patients, and also in agreement with the National Hemophilia Foundation, if you have a severe bleeding disorder, it's a good idea to use factor. Better safe than sorry. If you have a mild or moderate bleeding disorder, you simply might not need factor at all. If someone that I'm taking care of says, hey doc, I had a really bad hematoma with the vaccine, even though I have mild hemophilia, I would say, well, let's try to prevent that. Let's use factor before the vaccination. Use a small needle, apply pressure, the really easy stuff to do. If you're on Hemlibra for hemophilia A, you don't need additional factor. Hemlibra should keep your levels high enough where you don't get a hematoma, but it is gonna hurt. So this vaccine does cause pain more than a saltwater injection. I think it's a little worse than a flu shot. I've had lots of flu shots, but it's not being wailed on like Mike Tyson. But if you have a bleeding disorder, watch for swelling. That's the sign that maybe something is happening. Okay, so the fun part. Doc, I read on the internet. I say that everything we do has risks and benefits. Driving a car is usually the riskiest thing that we ever do. The benefit for me, I get to go shopping, I get to go to work. In the United States, every year there's a 13 out of 100,000 people risk of dying in a car accident, even if you're not driving the car. So in West Virginia, people here drive like maniacs, so it's actually 16.3. In Idaho, I think it's about the same. So that's the risk I take every day when I get into my car. If the ice is really bad and the road is crazy, I might want to stay home, right? So a vaccine was safe in the trials, but if it does cause a 1 in a million side effect, the trial is too small to see that. So the benefit for me of the vaccine, I don't get COVID. I tell people this that I work with. I'm not afraid of dying. It does not bother me. But I don't want to take COVID home and give it to my kid, my wife, or my patients. And that's the benefit for me getting the vaccine. If I get COVID and am in the hospital simply because of my age, the chance of me dying is 3 out of 1,000. That makes getting into a car look extremely safe, even though a car is pretty risky, right? So 2 patients just in the last week asked me, Doc, I'm so afraid. Did you hear about that guy? New York, Japan, Florida. I say, well, yeah. Did you hear about the 500,000 other people who died of COVID? So some things make COVID worse. These 2 patients who asked me, one has a blood condition. If she gets COVID, 1 out of 3, she dies. That's it. Another patient, 50-50. If he gets COVID, he dies. We know that they're high risk. Me being relatively young, I'm not a high risk person, but my job puts me at high risk of getting COVID. 2 or 3 times a week, people contact me and said, oh, crud, doctor, you know, when I saw you in the office, I got sick with COVID 4 days later. Well, good thing I got old reliable here, right? So for me, the risk of the vaccine was I went to bed 1 hour early after my second dose. I had a sore arm for 2 days. Some people say, well, I felt pretty miserable for 48 hours, but then I got better. There's always a risk of something very rare happening. But the internet, I read. All right. Well, by January 13th, 14 million doses had been given. And what we expected to happen did happen. We found a few rare things such as anaphylaxis, which is a serious allergic reaction. This happened in 62 people, so 4.5 out of 1 million. Guess what else causes anaphylaxis? Eating peanuts, eating dairy, getting stung by a bee. Yes, it's a reaction. It can be treated, and that's why when you get your shot, they keep an eye on you for a minute or two, make sure you're doing okay. Doc, I read about the guy in Florida, low platelets. So just so happens I see people with low platelets all the time. Now, out of those 14 million doses given, 20 people were noticed to have low platelets. 3 of those 20 had low platelets before. So could the vaccine rile up your immune system and your immune system attack your platelets? Well, yes. But that also happens without the vaccine. And it's hard to know that, well, the vaccine did it. In theory, yes, it could. But I also see low platelets in people who have COVID, far more than 20 out of 14 million. Other vaccines do cause anaphylaxis, like the flu shot, the shingles shot, and the COVID vaccine doesn't appear to be different from that. So a very good question someone with a bleeding disorder brought up. Well, what about gene therapy? If I get a COVID vaccine, does that mean gene therapy won't work? The gene therapy trials use a different viral vector, adeno-associated virus 5 or adeno-associated virus 8. This is different from the vaccines. So gene therapy puts that gene in your body for it to stay there. And how it does that is through a different way. So adeno-associated virus is not coronavirus. It's not adenovirus. It's a different type of virus. And the 4 vaccines we talk about today don't use adeno-associated virus. So there's no way that getting these will interfere with gene therapy, just like getting the flu shot doesn't interfere with gene therapy. All right, so in conclusion, the available vaccines are effective. However, no vaccine is 100%. The vaccines that are available now are really impressive. I wish a flu shot was as effective as these vaccines. The available vaccines are safe and low risk. Every treatment has side effects. Every treatment has risks. The side effects are, well, you feel kind of crummy. You have pain at the site. I got a big lymph node. It went away 2 days later. The benefit is I don't get COVID. I don't bring it to my family members. Vaccination, you might need to use factor to avoid hematoma, but a vaccine is not a magic bullet. It's a strategy to minimize the impact. I don't think COVID-19 is going away, but if my other family members had received their vaccine, I wouldn't be spending my Friday night trying to arrange hospice for my grandmother right now. So that's my personal take on the vaccine. Thank you, Uncle Greg. Your cold wasn't a cold and you just couldn't stay away from Christmas, could ya? So I'm a little one-sided if you ask me. All right, I will stop talking there. That is all I have to tell you. Be happy to answer questions if you have them. I think we have a moderator.
Yeah, Dr. Merrill, this is Michael Krieger from Idaho. We have one question that came through. You touched on it a little bit, but I want to ask it more directly so we can get the answer. I've heard some people say that they don't have to wear a mask after you get both doses of the vaccine and are hanging out with people who also have gotten both doses of the vaccine. Is it true, or should you continue wearing a mask during those times?
I would recommend the mask simply because vaccines are a great tool, but they're not 100%. And to be honest, We don't know how long the protective effect lasts. It looks like it lasts at least 4 months, 6 months, but we don't know, are we going to have to do booster shots once a year like we do with the flu? So I would still use a mask. And that's simply because what I see on a day-to-day basis is the horrible side effects of this. I don't see the people who don't get sick. And for me, I think of it as, hey, a mask is a minor inconvenience, but if it could prevent someone in the grocery store from getting COVID from me, or prevent me from getting COVID as I buy my sandwich bread, it's something I'm happy to do.
Thank you. Appreciate
So
it.
another question that we have is, can you elaborate on why the bleeding disorder community was not involved in the trials?
Yes. Yeah, when these trials are done, it's fairly tricky, because if they did include people with a bleeding disorder, that could influence the results. So not only are bleeding disorders not extremely common, but if you had 1 or 2 people in one arm of the trial and then none in the other, just because of chance, which is a realistic possibility, because you think if we grabbed 40,000 West Virginians and said, hey, you guys want to be in a trial, a few people with the bleeding disorder will be in one group and you might not in the other. That could make it look like the vaccine or the placebo causes more swelling or hematoma. And they also didn't want to include people with immune suppression for that same reason. So we are extrapolating that, well, this shouldn't cause any big problem with a bleeding disorder, but they specifically weren't included because during the trial, they didn't want to have to address, hey, what do we do if somebody has a hematoma? So we had to get a relatively uniform population of people.
Okay, thank you.
We have one.
Go ahead, Michael.
I was saying we have one more question. Is if you have a failed response to previous vaccines, Hep B or measles, would that influence which version is appropriate? I believe they're saying which of
Right.
the 3 that are currently available.
That is actually a good question, and frankly, I don't think anyone will know what the right answer to that is. So I'll give you some information about me. Throughout my years, I had to receive 3 different courses of hepatitis B vaccination because I never mounted a significant titer to it. Well, by the 3rd time, I finally got enough titers so I could stop getting this damn vaccine over and over again. We honestly don't know with COVID. And sometimes people will ask, well, if I have the choice, should I get this vaccine, A, B, or C, which one? Well, there isn't a great answer to that. And I would say if the truck shows up with the vaccine in it, I would take what they have. I don't think one vaccine is superior to another. The Johnson & Johnson vaccine is nice because it's a 1 dose, so you're one and done. The other vaccines, well, they have this higher number of efficacy, but that was also at a time when COVID really wasn't rip-roaring. So it's hard to compare apples to apples between the Moderna and the Pfizer vaccine and the Johnson & Johnson vaccine. The Johnson & Johnson vaccine, what they report is severe COVID. Well, very few people had severe COVID in the other trials.
So we have a few other questions. We are a few months into people receiving the vaccines. Are there any adverse effects that have been reported?
Yeah, so with the millions of doses that have been administered, there is the anaphylaxis, which is a severe reaction, an allergic reaction that can happen. That's been reported with other vaccines as well. And some of the news stories you might notice, they say, well, if you have a severe reaction to other vaccines, maybe you want to sit this out. And I have had some patients with bad reactions to a vaccine in the past. And if they're relatively low risk for COVID, yeah, totally, it makes sense. Well, if a vaccine caused a problem, doing a different vaccine maybe could make a problem happen. It might be fine, but that's the most pressing one that we see. The low platelets seems to be very rare, but is one of those perhaps 20 out of 14 million things that we see. And I recently saw a patient, they were wondering, could this person's low platelets be from COVID? It's really hard to know because when you don't have blood work on someone for 10 years, they get a COVID vaccination and then they're being assessed for a surgery and they're found to have low platelets. Well, did COVID make the vaccine make the low platelets, or did they just have low platelets and nobody bothered to look for a decade and now we found it? So it's hard to know.
A couple other questions. If someone gets a vaccine but they miss getting their second dose in 4 weeks, will they have to get first dose again? You may want to touch on the difference between first and second dose or lack thereof.
Right. With other vaccines that are available, if you miss a dose, there is what they call a makeup schedule. So you wouldn't have to go through the whole series again. Right now, because of how the vaccines are being administered, that unfortunately falls to the local governments who are administering it. And Krista later on might have more information on that, but biologically, you shouldn't have to go through the whole series again.
Great. Another question that's come in is, I've heard there's a chance the vaccine could cause infertility issues. Is this true?
That's a good one. So the infertility, that is something that was used by Boko Haram, which is the Nigerian branch of ISIS in Nigeria, to dissuade people from getting the polio vaccine. So it was fairly effective in some areas, but it does not cause infertility. The vaccine does not cause infertility. And what we do see, especially now when, social media is around and there's fear of the unknown, a lot of these ideas take flight again. But a lot of the things that you hear now worried about with the COVID vaccines, they're old sort of scare tactics that have been used in the past. And
so we have
go ahead.
Thanks. We have a few more questions, but we're actually going to pause on them. Let Krista have some time to speak, and then we'll jump back on. So if you're able to hang out for the remainder of the session, that'd be great. I'll turn it over. What's that, Wendy?
Thank you, Dr. Merrill. It was really, really informative. I really appreciate your candor and your expertise.
You're welcome. Thanks for having me, guys.
Mm-hmm. We definitely appreciate that. I'm going to turn it over to Fernando.
Hello. Thank you, Michael and Dr. Merrill. Now we would have Krista. And Krista, I lose track of all of your titles, so I'll let you introduce yourself and what your background and what you've been doing with West Virginia and the implementation plan, and let you share your information. And then if we have enough time, we'll come back to questions for you and Dr. Merrill. At that point, you guys can kind of tag team it.
Sure, absolutely. Can everybody see my slides? Okay.
Yes.
All right. Well, thanks so much for having me. I'm excited to be here. My name is Dr. Krista Capehart, and I am a clinical pharmacist and associate professor at WVU at the School of Pharmacy. As Fernando said, I do wear quite a few hats here in West Virginia. I teach at the School of Pharmacy, but I also have a position at the Board of Pharmacy here. And the role I've been playing with our state is actually I have been handling the distribution of our vaccine here in the state of West Virginia. And so I want to tell you a little bit kind of behind the scenes, if you will, about how that has worked. So I can give you more insight about how it's worked here in West Virginia, but as well as some insight about how it's worked in your jurisdiction. Just because there are a few pieces that are the same for various jurisdictions, and then some of the things that could be a little different. So just like Dr. Sam, I unfortunately also neither do have any real or perceived disclosures, so I don't get any money from any of these things either. So just to kind of give you some information here. So how does we get the vaccine from the manufacturer, from where it's manufactured to the state and into the arm? Well, once the companies were working on these processes, each state and jurisdiction across the country were instructed to have a planning committee. And I'll tell you, some of the states really did a lot better with this than others. We saw some states really take charge, get all kinds of doctors and pharmacists and nurses and public groups together and start to talk about how do we get maybe our faith-based communities and our health departments, and how do you get everybody involved? And some states didn't necessarily do as much in the pre-planning. And once the vaccine hit the ground, we really saw the difference of that. And every state was supposed to have submitted the plan by October. And the reason why I say I don't know how well that went was because as of November 2nd, less than half of the states had actually submitted a plan. And this kind of goes back to the fact that there is and has not been a central federal plan so that everybody is using the same central distribution system, if you will. What I can tell you that's the same is every single state in the United States is getting 2 allocations or 2 allotments of vaccine, if you will. They get 1 bundle of vaccine that goes to the state, and that typically is going to your state Department of Health or your Bureau of Health or whatever that group is called in your state. And so your state health officer and that group is deciding how that's going to be used. The other piece of that is the federal pharmacy program. And there's 2 pieces of that. The first one that got a lot of media was the first piece of it for the long-term care facilities, the nursing homes and those kinds of things. Well, now we're seeing the second piece of that, which is vaccine directly into the pharmacies for patients to be vaccinated. So every state has those 2 allocations, and it's kind of like oil and water. Neither the 2 shall mix. So the state doesn't go into the federal pharmacy allocation, and the federal pharmacy allocation doesn't go into the state allocation. Now they can work together, and that's actually what we're doing here in West Virginia, and I'll tell you a little bit more about that in a minute. So for the state allocation, each state decides, and their central organization decides how they're going to, where they're going to send that vaccine. So usually it's probably going to their local health departments. It may be going to their hospitals. So very early on, you heard that we were making our acute hospitals the first group of people that we were going to vaccinate. So Dr. Sam mentioned that he got the Pfizer vaccine. That's because every state sent the vast majority of their vaccine to their hospital facilities that were taking care of these very, very sick COVID patients. We needed to protect those hospital workers. We're now starting to see vaccine go to community clinics and primary care doctors. Now, there is a website called vaccinefinder.org, and that website, eventually when it's all rolled out and everything is functioning, will actually be a place, and there's plenty of vaccine, will be a place where people will be able to go to and find a location that has COVID-19 vaccine, and you can go and get it. Right now, there's just not enough supply, and there's only about 4 states, I think, that are reporting. And unfortunately, none of the states on our webinar tonight are reporting to Vaccine Finder. But that will be a place as vaccine becomes more available where we will be able to go eventually. So I wanted to kind of give you an idea where our various states, our 3 states currently are. All of us have had recent changes to who we're vaccinating. But it truly is that if you've seen one state vaccine distribution plan, you've seen one state vaccine distribution plan, because they're all very, very different. So here in West Virginia, just 2 days ago, we've been moving at a very, very rapid pace. We've actually just lowered our age to 50, plus some patients with chronic conditions, very specific chronic conditions. So we're doing 50 and up. We've actually looked at it in some counties, and there are counties in West Virginia that we've actually vaccinated everybody that wants to be vaccinated 65 and up. That's kind of hard for me to wrap my mind around, but I have some pharmacies that are trying to get people to vaccinate with doses this weekend, and there is nobody in their community 65 and up to vaccinate. So we've moved down to 50 and up, and they're still having problems to find. And it's simply because this vast number of doses have been sent, and we're doing kind of a two-strategy approach. We're doing large community events where there may be 2,000-3,000 doses sent to a community. And then we're also having doses from the Federal Pharmacy Partnership going into those communities. So if you take a county that maybe only has 20,000 people and you shove that many doses in a short period of time, you're going to run out and vaccinate that population pretty quickly. And we're seeing that in some of our very rural counties here in West Virginia. Now in Ohio just changed and began phase 2 on March 4th. And Ohio is now doing 60 and older, and then they also have some specialty groups. And then in Idaho, Idaho has a very interesting program. Idaho is still in the 65 and older. All their healthcare workers, long-term care facility staff and residents, first responders, their teachers. And both West Virginia and Ohio also have their occupational groups that they're also focusing on, including their K through 12 teachers and school staff. So we're seeing very similar groups, but they definitely, the ages are a little bit different. The way the federal government is doing the allocations is based on your population, how much population you have. And here in West Virginia, we're just a very low, we're not a big state. And we've been very meticulous with the rollout, and we've been sending doses to the counties based off of their 65 and older population. And so it's gone pretty quickly. The other thing that we've had in West Virginia going for us is because of the way we've had it planned, we have literally been getting 100% of our doses that we received each week into the arms of patients each week. So we have not had doses sitting in freezers each week because they've all been going to patients. We've known exactly which group we were vaccinating. So I think that's been something that we've been really proud of. But as we get farther into the vaccination process, that's getting harder and harder because it's harder to find those patients. And as we've started to see the cases decline, which is an absolute result of our vaccinations. I know I saw some of our statistics the other day, and we were very, very deliberate here in West Virginia to vaccinate. We split our initial supply between our hospital workers and our nursing home patients, because our nursing home patients, they were only about 7% of our cases in West Virginia, but they were over 70% of our deaths. And so that was one of the reasons that we absolutely vaccinated that population. But some data came out this week that showed our deaths have actually dropped by 85% in the first 6 weeks of the year. So we're really excited about that and the results of the vaccine. But everybody wants to know, how do I get mine once it's my turn? Well, again, every state is so unique. Ohio is working on, they're getting ready to roll out a new vaccine management system for their providers, which is actually going to help them be able to identify, schedule, and register the patients that want vaccine. They already have a map that you can go to to where you can click and see where vaccine has actually been sent. The issue that I'm hearing from Ohio providers is that they may have already gone through all of those doses. So, but Ohio's working really diligently to get that system up and running so it will be more real time. West Virginia and Idaho both have a statewide registration system. Now, our system in West Virginia, we actually are going ahead and registering all patients ages 16 and up for the vaccine. And then when we have a clinic in that county, we will actually run, let's say we're doing patients 50 and up, we'll run a list and start with the patients that are oldest first in that system. And I think with like any type of system like that, every state is struggling, us included, but we're trying to at least get to the people who want to be vaccinated. And again, we're seeing that some counties, everybody that's registered, we are already vaccinating. And as the more doses become available, that's actually really good news, because that means we're getting to the people. Now we have to get, as Dr. Sam mentioned, we have to get more people to want to be vaccinated, because that's going to help us get back toward our normal. And then with Idaho, they do have a statewide registration system, which is nice. However, when you go to actually find where you go to get your vaccine, each individual district has their own website and hotline number with separate hours. So it can be a little bit difficult to actually navigate to find where you want to get, or where you're going to get your vaccine. And that's something that we're really hearing across the country, is that, you know, they tell me I'm qualified to get my vaccine, but how do I go find it? So I think more than anything, every state is very, very different. That's partially because there was no central process. Now, that's worked very well for us as a state here in West Virginia, because both at a state level as well as our local level, we knew what we needed to do because our local communities knew their area well. But it hasn't worked well across the country. We've actually coordinated both our state program and our federal pharmacy program, so that both of those are actually using out of that same state same state registration system, so that we don't have people jumping in line or vaccinating around the system. So everybody's coming out of that same online registration system. And so I think if the two programs can work together, both the state allotment and the federal, we see a lot more cohesiveness. You know, anytime you have team-based care, things tend to work better. And it's been a pretty nice program. We have what we call the Joint Interagency Task Force here in West Virginia that's done all of our planning, and every agency in the state, so your hospitals, your local health departments, pharmacy, everybody has a seat at the table, and we're live in the same room working to make those decisions. And it's resulted in a much clearer picture, and usually, although we've had our fumbles, usually much clearer presentation and communication. So I would just encourage everyone to be persistent, follow your updates, go to your local public health websites, and you know, be your own best advocate. Make sure you're following when it's your turn to get your vaccine and how you get on that list, because that's really going to make you be able to get your vaccine as quickly as possible. And I did want to mention one of the things. I think one of the questions that had come up was, since we've been giving vaccine for 2 to 3 months now, we're about at the 3-month mark. I wonder if that question was more of, have we seen long-term side effects? So I did want to mention one that that we're monitoring at the state level. The only thing that we have seen from more of a long-term is what we are seeing, which tends to come about at about 7 to 14 days after, with actually more the Moderna than the Pfizer, although it does happen with both. And it is actually a typically a a skin rash. And so that's one. It was actually just published in a medical journal this week. But that's really the only long-term side effects that we have seen from monitoring all of the data. And so I did want to bring that one up because I wondered if that question was going that direction. So that's what I had. I will finish up there and then we will get back and I'll answer any questions you guys have.
Thank you so much, Dr. Capehart. Appreciate you providing that information, and thanks for looking into all the different states that are represented today. One of the questions that came up during your talk was, I have Mickey Mouse behind me, my son, sorry, so this is from someone from West Virginia. They want to know how they follow where you are on the list, as the system does not provide the info even once your group is eligible.
Yeah, and that's actually something that we're working on, trying to provide more frequent updates for the individual. And it's hard to tell because it depends on how many in your county are getting, how many doses are going to your county for that week, and how many people register in an older age group than you. Because what happens is it's not in the order in which you register in the system, it is your age group. So let's say you started, you registered 4 weeks ago, and let's say I'm 55 and I registered 4 weeks ago. And I just became eligible. Well, we put those in, but if there are still 580-year-olds that are in your county, those 80-year-olds are going to get pulled and vaccinated before the 55-year-old. So it's really difficult to give a time, given it's all dependent upon how many doses your geographic region is getting and how many people are registered in your county. So we're working on a way, though, to kind of give you an update. I can tell you, though, that given the amount, I would say we're very, very close to getting through our lists. But we had 17,000 more people register yesterday. So every time I think we're getting close to getting through the lists, people surprise me and we have 20,000 more people register. But we are working on the communication methods to get more information out to people.
Great, thank you. Another one popped up. I understand the bleeding disorder community isn't necessarily at a greater risk for COVID. As a community member that is in that 25 to 45 range, that they would be considered one of the later ones to be eligible for the vaccine. Are they considered to be in a health compromised or pre-existing group that may be expedited at all, or is it you just kind of have to sit and wait patiently for your group based off age?
Well, anybody that has, so if you're in West Virginia, the way we're doing it is we have taken specifically the health conditions that we know are at higher risk, but then we will move on to all chronic conditions as the governor and the leadership team direct us. So my guess is we'll hit the higher risk chronic conditions, and then we'll go to all chronic conditions, and then we'll continue to lower the age. That's at least what the leadership team is looking at.
Perfect, thank you. And I caution saying this because of Dr. Merrill I read on the internet, but today I did see, because on Facebook you're in these groups based off of location. So I live in Kuna, Idaho, and someone said there's a bunch of vaccines at the local Walgreens. It doesn't matter about the age. Come and get it. So one, how valid would a statement like that be? And two, if you have to come 28 days later, does that supersede being like, I already have one, I should get number two? Or they can say, well, you're not in the eligibility pool.
Yeah.
It
It depends on a couple of things, okay? Because the federal pharmacy programs have to rely on what the state qualifications are to get to give out the vaccine, okay? Just like everybody else. So I would be very hesitant to agree with the social media post of everybody's available. Everybody come one, come all. However, there is an exception to that. I sometimes feel like Oprah. You get a vaccine, you get a vaccine, you get, oh, you know, all right. Sometimes it feels like that though. There is one exception to that, because when a vial is opened, every dose must be used within 6 hours. So if you have a Moderna dose, if you have a Moderna vial, and we know we get 10, sometimes 11 doses, and it's close to you know, that's going to expire at 6 hours. There could be a situation where if they don't have any patients around, that could be valid. And if you get your first dose, you should be guaranteed your second dose, because it will come back to that store.
Okay.
Perfect. One question we had in the chat was, how are you measuring success with the vaccine distribution process?
Ooh, that's a really good question. I ask myself that one every day. Let's see. We've had 4 goals here in West Virginia. One was to make sure we were protecting our acute care centers. We were protecting the most vulnerable. We were reducing deaths. But for me, I want to make sure that I'm hitting the populations that we need to, that are the most vulnerable. I'm reducing deaths. But the other thing that is most important to me is that I don't have, at the end of the week, when I know I have more doses coming in, that I don't have doses sitting in a freezer that we could have used to save a life. I think that people would hold back doses that could have been used to save someone's life simply because that person didn't fit in some criteria is really heartbreaking to me, because that we know doses are going to come next week. And if we could have saved a life this week, regardless of if they fit in some arbitrary criteria, that's really, that to me is one of my primary criteria that I try to drive home in terms of, are we being successful? And so as I planned out the long-term care facility program, the K through 12, we're very, very clear with entities that I'm only going to send you the number of doses that you have patients there for, because I'm going to make sure that the other doses are going to the other people that need them.
Thank you. Some of the questions we had from previous, kind of open it up, and whoever wants to take the lead on the question. Is there an increased risk for anaphylaxis for someone who is on a factor that has PEG in it, pegylation?
So the honest answer to that is we don't know, but the PEG moiety that's attached to factor is a different molecular weight than what is attached in the vaccines. And PEG itself, you can have PEG in your body from your factor and not have a problem with the vaccine itself, but that's no guarantee that you won't have that allergic reaction. But what seems that we notice is that if you are someone who has anaphylaxis to other things, you would be expected to have a higher risk. So if someone said, hey, I had anaphylaxis to 3 different medicines, I would say, well, you're probably higher risk of anything, whether it's a vaccine or hanging out with my cat on the sofa over there.
One question that we've had, it's an older question, was from a mom whose son has severe factor 8, and she is concerned. She's getting her vaccine, but she's concerned about her son. He doesn't qualify for the vaccine because of his hemophilia and HIV.
Yeah, and that's a good question about children as well. So they are doing trials in pediatrics to try and see, because right now it's, well, you have to be in this age group. We don't know, I don't know when we'll have an answer in terms of when children can get the vaccine. But it is something we're eagerly awaiting, myself included.
They're actually telling us the information that we're getting back is potentially by midsummer to late summer is what we're hearing, because they have actually already started those trials, but they are having a bit of difficulty recruiting for them.
Dr. Merrill,
Great.
can you tell me, one of the questions that I've received as an ED is, how long is the time span between when you receive your vaccination and when you're actually, because in your talk you had said, if you get the shot 5 minutes from now, you touch your eye and you get, so what is that time frame? How long does it normally take for the vaccine to start taking effect?
From the studies and the graphs there, it looks like about 2 weeks after your first dose, that's when those two curves start to separate.
Okay.
So if you got your first dose now and got exposed to virus in 1 week or 2 weeks, I would think you're having a protective effect. And that's actually one of the things my family members are texting, because they've all been taking care of grandma. So it looks like 2 weeks after your first dose, there is some of that protection there by that time, which makes sense with how the immune system does get trained up. We see that the antibodies start going through class switching usually about 2 weeks after an antigen exposure.
Perfect.
Krista, I had a question for you. There has been a lot of discussion and updates as production increase and the supply goes up, demand goes down because people are getting those vaccinations. From someone in the inside, what is your expectance that supply will no longer be the major hurdle in vaccination in the United States from a date perspective? And if that's a month, I think that'll be okay.
I think this week is the first time here in West Virginia that we've really seen. We saw a huge influx of vaccine here in West Virginia this week. Our federal pharmacy partners got a huge influx, and then we also, as a state allocation, got a huge influx. And we've been told that that's going to continue over the next month. And as we look at that, I'm truly thinking that, we could, looking at the numbers, I mean, we really may be looking at potentially under 50. I mean, I hate to give a month, but I mean, we could be looking at under 50 by the first of next month, even if not sooner.
Wow.
I mean, we actually got close, and I mean, okay, Idaho and Ohio, just give me a break here. But we were only getting 22,000 doses a week, and we jumped up to over 80,000 doses this week. So when you look at that enormous comparison, it's that just gives us an opportunity to hit so much of our population. And so I wouldn't be surprised if we're, and actually what we have started to see is, because the cases have gone down, people have said, I'm not really sure I need to get that. And that's something that we're starting to, they've waited and now they're considering changing their mind.
Thank you. We did get a question on the chat that I think is a very good question. It asks that this person has seen a picture of the COVID arm that you mentioned, Krista, but how would you as a caregiver see the difference between the reaction and an actual bleed cause as a site when the child in question has never had a bleed, will likely not be able to identify the bleed himself? And they did say that this is more of a future question from a pediatric standpoint.
It would be tricky in a child, just because if they're not able to tell you what's going on, if they don't know what a bleed feels like, a hematoma in the arm shouldn't be so much a rash on the surface, but it would be a sort of a painful swelling deep down in. So if you were to see the rash on the surface and, well, it's on the surface of the skin, versus, hey, their shoulder seems kind of puffy, and when you press on it, they say, ooh, that would lead me to suspect the hematoma itself.
There was a follow-up question to one of the questions that we asked about HIV and Hep C. So wanted to more like a clarifying, I guess. So it's an adult son who has HIV and Hep C, but still does not qualify for the vaccine for one reason or another. Want to know why there is no vaccine for HIV after all these years when there was expediently a process to get one for obviously for COVID.
Right. Yeah, unfortunately, there's been a huge effort in the medical community to try and get a vaccine for HIV. HIV is very tricky because of the nature of the virus itself. It goes through such rapid changes that by the time you make a vaccine for it, it's already changed enough that it isn't sufficient for the immune system to recognize it. This is something very similar to one of the worries now with these variants that are popping up, because over time the viruses will change. If they are capable of changing faster than we can defeat them, we'll always be chasing our tail. So you may hear about these South African variants or the UK variant. The virus can pick up mutations over time that help it be more successful. So there is a real worry that one of these variants will escape from the vaccine and that you'll have to change the vaccine. Just like a flu shot, for example, the flu shot that I got 3 years ago, well, it doesn't really help me today because the flu has changed enough in that time. And for Hep C, it's very similar. Just had another study that I read about a Hep C vaccine that it didn't work. So after all these decades, so HIV, Hep C have not worked, unfortunately. There are other viruses where people have tried but haven't worked. So the viruses change, and if we can't keep up with that change, they're really hard to outmaneuver.
Perfect. One last question that we have is that schools are reopening and the teachers are getting vaccinated, but this mom is concerned because her children who are 16 and older aren't getting the vaccine yet because it's not their turn.
Yep, I'm right there with you. I have twin 16-year-old girls, so I completely understand and empathize and sympathize with you. The reason that we are not opening it up in West Virginia, the reason is because we are actually looking at essentially, if you will, the end results of the COVID and who is most likely to be at risk of long-term severe consequences and ultimately death. And that is not the 16-year-olds. That is the 40 and up, the 50 and up, the 60 and up. And so I know here in West Virginia, as we vaccinate those populations, we'll ultimately reduce it down to the 16-year-olds. But the 16-year-olds are not the ones that are ultimately, they're surviving the having COVID and doing much better than those teacher ages. And so that's ultimately why we have not done that here in West Virginia. But I'm right there with you because I have twin 16-year-old girls.
Yeah. My 18-year-old actually got COVID and she basically had a cough and like for 5 minutes and she was fine. So, but it is scary as a parent. You don't ever want your children to be sick, and sending them to school should not be something that you worry about. So I totally empathize with that.
Well, we did try to strive for an hour and 30 minutes. We are just a couple minutes past, but thank you so much, Krista, Sam, for your time, your knowledge and willingness to hop here on your Friday night to share that information with us. Also wanted to thank the Idaho and Central Ohio chapter for once again partnering with the West Virginia chapter to provide this education. If you have any questions, please direct your questions to your respective directors, and hopefully that might be something that we can get you connected with Sam or try to answer your questions. But as always, reach to your local hemophilia treatment center, your hematologist for any follow-up questions. Thank you very much and have a good night.
Thank you, Fernando.
Thanks so
Thank
much
you
for
all.
having me.